Hello, everyone. Thank you so much for joining us. We have a few minutes before we get started, but just to learn a little bit more, my name is Ashley. I'm a medical science liaison with Baxter. And as we get started, I will introduce our wonderful speaker, Dr. Valerie Hooper. But before we get started, do we have, I see we have people joining already and just want to know to learn a little bit more about our audience. Can you all just put in the chat where it is you're joining from and what is your title? What is your current work position? I would love to learn more to see where everyone's joining from. I'm in Chicago, where it's getting a little cold, so hopefully you all have some sunshine and some weather that's not too chilly right now. So I'll be looking to see where everyone's joining in the chat. Very nice. We have Louisiana. Oh, administrator at a ASC. Very nice. We have Pennsylvania, Oakland, Illinois, not too far. You're chilly with me, Christine. Ventura, California. I'm sure it's a little more sunny that way. Minnesota. Very nice. Kentucky. Oh, very nice. New Mexico as well. Awesome. So we have some surgical services directors. We have OR staff nurses as well. Very nice. Chicago. So we have quite a few Illinois people. Great. Welcome. Thank you for joining. Thank you so much. So we'll just wait just a few more minutes before we get started. I see we have Texas as well. Awesome. Oh, Philly. Very nice. I'm sure all of you are feeling the change of the weather then that's coming. So we'll just give a few more minutes, just allow everyone to come in, and we will get started here very shortly. Oh, also Kansas, and we have charge nurse. Very nice. Thank you all for putting that in the chat. I appreciate your feedback and your participation. And it looks like we just have one more minute and we'll get started. Okay, so it is time. So we'll go ahead and get started. Thank you again, everyone, for joining. You are now joining us for our Unplanned Perioperative Hypothermia Risk and Prevention webinar. Once again, our wonderful speaker will be Dr. Valerie Hooper, and I will introduce her very shortly. Just want to give you some reminders. So this webinar is sponsored by Baxter as a learning activity, but the content of the presentation is completely developed by Dr. Valerie Hooper. During the presentation, all the lines will be muted, as well as cameras off for now. But if you have questions during the presentation, please feel free either to use the Q&A option in your toolbar, as well as you can add questions in the chat. And we'll be sure to get to those questions at the end of the presentation. We'll have a few minutes towards the end for a Q&A session. Any questions specific to Baxter products can be directed to our medinfo@baxter.com website or email address, excuse me, as well as the medinfo.baxter.com website. So this will be recorded for educational purposes, and a link will be provided to you all afterwards as well. So once again, welcome and thank you for joining. And with us this afternoon, we have Dr. Valerie Hooper. Thank you so much for joining us. We really appreciate you coming and bringing this information to our audience. And Dr. Valerie Hooper is a senior nurse scientist with Ascension, as well as a co-editor of the Journal of Peri-Anesthesia Nursing. And Dr. Hooper has been a nurse for over 35 years with a primary focus in peri-anesthesia and perioperative nursing, working as a staff nurse, a clinical nurse specialist, and lastly, as a clinical nurse scientist for the last 15 years. And Dr. Hooper's primary research interests include clinically focused patient outcomes research, and that's to include a particular interest in the effects of unplanned perioperative hypothermia on patient outcomes for all of your patients in the operating room. And Dr. Hooper is a fellow in American Society of Peri-Anesthesia Nurses, as well as the American Academy of Nurses. So please welcome Dr. Valerie Hooper. Thank you again for joining us, and we will get started.
Okay, thank you so much, Ashley. Appreciate that introduction. And hi to everyone. It is, let's see, I got to remember how to, down here at the bottom, a little bit of techno issues. I had to figure out how to change my slides. So, but I think we're good now. It just is so wonderful to have everybody, and how fitting that we are talking about hypothermia in what is, for most of us, many are starting to cool off and have some very frigid temperatures. So I do want to just give you a little update. I told Ashley earlier. I live out in the country. I live in Western North Carolina, and we are still having some power issues from the hurricane. And I am on a generator right now, but if I should disappear, I will come back, and I will just rely on Ashley to kind of entertain everybody while you're waiting for me. But hopefully we will be able to go forward without a hitch. So what we're going to be doing today is talking about unplanned perioperative hypothermia. I will say I've been, good grief, I started in the PACU in 1987, which sometimes shocks folks because it was before pulse oximetry. But it was also before we had high-tech warming methods, such as forced air, the convection heating, the warmed OR tables, etc. So I can remember getting patients out of the OR, 12-hour big belly cases that were 93, 94 Fahrenheit. And you'd spend they'd come out usually on the evening shift, and then you'd spend the entire night there warming them up because you had to warm them up to extubate them. Then you had to keep them a while before you could take them to the unit. So hopefully we don't see as much hypothermia as we used to. But I think it's still important to be very aware of the issue and aware of the best approaches to prevent the issue. So the objectives, we're going to have a basic discussion about the impact of anesthesia on the body's thermoregulatory process. We're going to discuss appropriate temperature measurement approaches, because if you don't measure the temperature, you're not going to know if they're hypothermic or if they're normothermic. But if you don't use the appropriate measurement technique, you may get a false high or low reading. So we want to be measuring appropriately. We want to talk about risk factors for the development of hypothermia, and then more importantly, we want to talk about evidence-based interventions to prevent hypothermia. And if you'll notice, I talk more about prevention than I do rescue. The ideal is that the patient should come to the PACU normothermic. That is the ideal. And if we do our job pre-op and intra-op, there's a very high likelihood that they'll be normothermic when they get to the PACU. So a little bit about me and where I am at. I am a senior nurse scientist at Ascension. I work nationally, and I am very fortunate to also work remote. So I work remote from home out of Western North Carolina. And this is our leadership team and our research team. And just a little bit about Ascension. I think I can best summarize it in that we are the third largest healthcare system in the country. And you can see the map where we have a footprint in all of these areas. So we have 136 hospitals. So that's a lot of hospitals, it's a lot of ORs. And we have about 48,000 nurses. And 50, a little over 500,000 surgical visits every year. So we're big, which allows us to do some really interesting and fun research. But let's get started on the guts. What are we wanting to talk about? So when we talk about unplanned perioperative hypothermia, the first thing we need to understand is basic thermoregulation. So the body normally maintains a temperature in a very narrow window between 36 and 38 degrees Celsius. Now that's a core body temperature. Our body temperature is controlled through both physiological and behavioral responses. Our house was a bit chilly this morning when we got up because we lost power and it was in the teens. So behavioral, I had several cups of hot tea this morning. I've got a blanket in my lap. So I go stand in front of the fireplace and try to warm up, wear extra layers. So we have normal interventions that we use every day to either warm ourselves or to the opposite end to cool ourselves by cutting down the air conditioning, standing in front of a fan, etc. There are also normal physiological responses to maintain that narrow 36 Celsius to 38 Celsius window of temperature. When we're hot, we sweat. When we're cold, we shiver. We have piloerection or goosebumps. We'll vasoconstrict whenever we're cold. There are some people that their nail beds will actually get a little dusky looking when it's extremely cold. And of course, the risk for frostbite is because we vasoconstrict, because the body's goal is to maintain the core. When we're hot, we will vasodilate, which will often, folks will have red cheeks and their skin will turn redder and warmer. So we have normal means, physiological means of maintaining our temperature. But what happens with anesthesia? Well, with anesthesia, you basically turn into a frog. And what I mean by that is anesthesia, both general and regional, causes the body to be poikiothermic. So the body temperature, like that of frogs, snakes, amphibians, the body temperature without intervention is going to migrate to the temperature of the environment. And we all know that typically the surgical services environment is chilly. on a good day. And I can remember when I was staffing and in the PACU, we would have fights over the thermostat as to how warm or how cold. In the OR, it's always a battle to get that room temperature up because of all the lights, the layers that folks have to wear during surgery. But Porciothermia, so when you see frogs in the cooler weather sitting on a log in the sun because they're trying to warm up, or in my area in the summertime when it gets warm, we have to be very careful if you're reaching under a bush because snakes will go under the bushes to cool off. So with anesthesia, we turn into a frog, essentially. So what happens is without anesthesia, the body's core temperature, where the core temperature is regulated, the core is basically consists of the gut, the heart and lungs, and the brain. And the body is always going to prioritize these areas when the external environment is extremely hot or extremely cold. But when you get exposed to anesthesia, then that ability to thermoregulate becomes blocked. And so the core extends out into the extremities, therefore naturally dropping the core temperature. So how does that temperature drop occur? In the OR, there are basically 4 primary methods of intraoperative heat loss. Convection is the loss of heat to wet drapes. The fact that the OR has more rapid air exchange. So we may not notice it, but essentially there is a breeze, a continuous breeze in the OR as air is more rapidly exchanged than it is in other parts of the hospital. Radiation. The bigger the incision, the larger the surgical field, the more heat you're going to lose from radiation. I am an old MASH fan. I grew up watching the series MASH. I still, if MASH is running all day on the TV, I'll tend to watch it. And there is one episode of MASH where it's extremely, extremely cold outside. Of course, they're operating in tents, and you will see the surgeons warming their hands over the surgical field. Because when you cut the gut open, it's warmer than the environment. That internal gut temperature is warmer than the environment. You're going to lose heat in that open surgical field. Evaporation. This again, you're going to lose heat when you're intubated, particularly if if we're not using warm air for ventilation. If you've got wet, cold irrigation, that's going to evaporate. And you're also going to lose heat with irrigation. You can lose it through evaporation, but then if you have your surgical drapes are wet from the irrigation, you're going to also lose it from convection. And then also conduction. So this is where the temperature of the OR table is so important. And if you want to prevent heat loss, having an OR table surface that is warm can help alleviate that. Because otherwise, when you put that warm patient on that cold table, think about getting into the bed in the wintertime. If you, particularly in cold areas, a lot of folks, they've got an electric blanket will heat the bed up. If you don't heat the bed up, it takes a bit. You know, you hop in the bed, you're shivering, you're pulling the blanket up, under your chin because you are losing heat via conduction onto the cool bed sheets. But we also need to think about conduction when we're moving from the PACU and the PACU stretcher up to the floor. And if that patient is barely normothermic, we take them up to the floor. Then we move them from that PACU bed, which they've been on and they're warm, and we move them into a fresh bed with fresh linen. They may have another temperature drop. They may have some after drop after they get to the floor. So this heat loss perspective is very important. We just had a flicker. Ashley, have you still got me? Are we on?
Yes, you're good.
Thank you.
No problem.
So when you move the patient to a cold bed from the PACU, if they are very barely normothermic, we need to remember to encourage the staff in addition to all of those other critical vital signs that they're looking at post-op, to also keep a close eye on the temperature. So because of the vasodilation and all of those ways in which we lose heat in the OR, if you look at this is the basic temperature trajectory during anesthesia. So the patient's going to come in normothermic, but then you see they are going to just crash from a temperature perspective as soon as we begin induction. And they're going to lose temp even if we are actively warming them in the OR. The thing is as long as we're actively warming them, they aren't going to have as significant of a drop, and hopefully they may lose temperature but not drop below that hypothermic baseline of 36 Celsius, which is the basic definition of unplanned perioperative hypothermia. But notice it's a core temperature of 36 Celsius. So the important thing is we've got to figure out how do we measure a core temperature. So when they're in the OR, and particularly if they've got general anesthesia, measuring a core temperature is pretty easy. Because you can also always use the distal esophagus, and you can drop down a temperature probe down in the esophagus, which is pretty standard care, and be able to continuously monitor a core temperature. If it's an extremely big case and they've got a pulmonary artery, PA catheter, that's going to give you a core temperature because that's resting right there in that link between the right ventricle going out to the pulmonary artery. You can also capture a core temperature with a thermocouple tympanic membrane thermometer. This is not the infrared temporal artery thermometer that we had came out years ago that you stick in your ear, and hold the little button. The ones you can buy it at Walmart or Target, though a lot of folks also use at home. That is not a thermocouple. That is an infrared tympanic thermometer, which is not accurate. The most accurate non-invasive near core sites are the bladder, but that means you've got to have Foley, and we're trying to avoid a Foley. We may have one intra-op, but ideally we should pull that as soon as we can post-op. And you've got to have enough urine flow to give you a temperature. still to this day, the most accurate non-invasive near core site that's easily accessible for everyone is the oral temperature. And I call it a tonsil temp. You've got to stick that thermometer back in either the right or left buccal corner, buccal corner of the oral cavity. You can't just put it right at the tip of the mouth. You've got to really stick it back there. And that will give you an accurate core temperature measurement, non-invasive, even in an intubated patient. Now, some new technology that we also have is the zero heat flux thermometers, which I've got the picture there. It's a little sticky that goes on the head, goes into the monitor, and that will allow you to have continuous temperature monitoring. And this has been used very frequently also in the OR for regional cases or cases with LMAs where they need continual monitoring, but they don't have the distal esophagus access. Now, what is not accurate? And this I want you to think about. What are y'all using? Those little stickies that give you a range, the forehead skin temperatures, those are not accurate for a core temperature. They'll tell you if it's going up or down, but it's not a core. Infrared tympanic, infrared temporal artery, also not a core. Infrared tympanic is too dependent on user technique. If the patient's got a lot of wax in their ear, everybody's ear, you have a different angle. I can remember when we used to scan and scan and scan with a tympanic until we got the temperature we wanted. So if you've got tympanic thermometers, and I know we had some administrators, you need to get rid of those. Infrared temporal artery. Infrared temporal artery is fairly accurate as long as the patient's in the normothermic range. As the patient gets extremely hypothermic or extremely hyperthermic, they become less accurate. Infrared, when you look at the literature, was also tested against a rectal thermometers because infrared temporal artery thermometers originally were marketed towards children. Rectal temps can reflect core temperature, but they change very slowly. And if you think about it, so a rectal temp doesn't change fast enough to reflect that rapid decrease in temperature that we get in the OR. So if you are using infrared temporal artery, or most folks would not be using rectal, but if you're using tympanic and temporal artery, you're not getting a good core temperature measurement. The thing to remember, though, is to also try to use a consistent method. So if you're using one method in the PACU, but then you go to the floor and they're using an entirely different method, you're not going to be getting consistent temps. You're going to know if the patient's going up or down, but it's not going to be consistent temps. So understanding risk factors. So what are the risk factors for unplanned perioperative hypothermia? The primary risk factor is anesthesia of any type. General or regional, the patient's going to be at risk for hypothermia. So that is an intrinsic risk factor that we cannot change, right? The majority of our patients are going to receive general or regional anesthesia. And even in our interventional radiology cath labs, they may just be receiving some light sedation, but because they're on that cold OR table, and again, the procedural rooms are cold, they will also be at risk. There are several other risk factors here. And as you can see, I always think of risk factors as intrinsic and extrinsic. Intrinsic is I can't change it, but I need to be aware of it. Like they're having general anesthesia, a 12 and a 12-hour big belly case. And I'm probably dating myself a little bit, but we used to have patients, and in the OR, they were open from right below the chest all the way through the rectum, and it was a 12-hour case. Because you've got so much exposure, you know, the little forced air warmers that come in pieces, you've got too much exposure. Maybe you can have one across the chest. You've got a 12-hour surgical duration. So you've got to look at the situation and go, where can I warm? Well, the place that's going to touch the most body surface is going to be the OR table. I am finding in talking with some of my folks, my OR directors, as we're moving into robotic surgery. I had a colleague, and they did their first inguinal hernia case. It was a 5-hour case. And because of the robotic technology, you can't cover the top of the body surface. So again, you've got full exposure. So your only place, and while you don't have surgical incisions that are as big, because they are exposed to the environment, you're still going to have a lot of temperature loss. And this is where being on a OR table where you can maintain temperature is going to be very important. So why do we care? You know, why do we care about hypothermia? I've got several reasons here. I've got patient discomfort at the top, and I know from a physiological perspective, that's not life-threatening, but I have done a whole lot of pre-op interviews in my life. And you always ask, have you had previous surgeries? Did you have any complications with your surgery? We're trying to get to, did you have complications with anesthesia? Are you at risk for malignant hyperthermia? Invariably, what patients will tell you, if they have a memory of surgery, they remember being cold. They remember being cold. They remember waking up shivering. So that patient discomfort is very important. Now, other physiological complications, increased adrenergic stimulation, which is going to lead to cardiac events. Coagulopathy, you're going to have more bleeding. You're going to have altered bleeding with hypothermia. Altered drug metabolism. It's going to take them longer to wake up. Because of the vasoconstriction, they're going to be more prone to surgical site infection and problems with wound healing. I think there's some preliminary research out there about hypothermia and post-op pressure injury. Because again, if you're laying flat on a surface, hard surface, you're not moved for a 5-hour case and you're hypothermic, those pressure points are going to be more prone to post-op pressure injury if we don't take preventative interventions. This is going to increase your PACU length of stay, and some of these complications can also increase your hospital length of stay. So how do we manage it? The number one solution to post-op or to unplanned perioperative hypothermia is to prevent it. And with today's technology, there is no reason why we should be having unplanned perioperative hypothermia. So let's talk a bit about warming. And the first thing we need to understand is the difference between passive warming and active warming. So passive warming, you see that blanket warmer. Most common thing we think about in the perioperative area with passive warming, the most common intervention we use are those nice warm cotton blankets. They are wonderful for you as a nurse. If you're cold in the PACU or running around in the back, patients will tell, I've also had patients tell me that the thing they remember most is that nurse giving them that nice warm blanket. And that nice warm blanket is important because it improves patient satisfaction. It will prevent further heat loss. It's passive. It's not going to actively warm. It's not going to re-warm the patient. It's not going to increase their temperature. Other passive warming, I used to call them French fry lights. Prior to forced air, we had a hypothermic patient. We put the lights over them, covered them up with a bunch of cotton blankets, sometimes put a plastic layer, like a plastic trash bag on top. I don't know what the science is for that, but we thought it worked. But that's passive. It's not going to actively warm. And of course, in real life, passive warming, you know, if you're standing in front of the fireplace, that's passive warming. Having a hot beverage, passive warming. What we really need to be focused on to prevent hypothermia, pre-op and intra-op, is those evidence-based active warming interventions. Forced air, warming IV fluids, warming OR irrigants, warming your gases. And then again, the OR table surface. If you can get that convection heating coming up from the OR, conduction heating coming up from that OR surface. And that's where you're going to get the greatest body coverage, is coming up from the OR table surface. So preoperatively, what's the secret to prevention? First, identify the patients at risk. Add pre-warming. And then that's going to help you with preventing hypothermia. Now, you need to, all of the guidelines will tell you, unless it is an emergent case, a patient should be normothermic before they go to the OR. We should never send a patient to the OR hypothermic unless it's like an emergent case, a trauma, something of that nature. The evidence now is truly starting to build about the effectiveness of pre-warming with forced air prior to sending the patient back to the OR. Now, the evidence is very mixed on how long should that patient be pre-warmed. I've seen literature that's shown 10 minutes up to like 30 minutes. So I think really the rule of thumb should be as soon as you can get that patient the pre-warming blanket, forced air on the patient, you should preoperatively, you should get that on them. And now there is equipment that will actually allow the patient to adjust the temperature to their comfort level. What that preoperative warming does is the patients, if you'll notice, the top line on this slide is the patients that were pre-warmed. And if you'll notice, they start out at a little bit higher temperature because of the pre-warming. They're still going to drop, but the drop, that slope is not as steep. And also because they're warmer, even if they drop, they're not going to drop below 36 Celsius, which is what you're seeing on the bottom line with the patients that were not pre-warmed. So there is good physiological evidence on the effectiveness of pre-op warming. And I also know we had some folks join that were in ambulatory surgery centers. And we've always kind of had this attitude, particularly for the short, sweet cases, that, oh, that's a short case, it's less than an hour, we don't need to pre-warm, and we really don't need to worry about warming too much in the OR. Well, when does the greatest temperature loss occur? It occurs in that first hour of surgery. So if it's a 30, 45-minute case, that patient's still going to lose temperature. So we still need to be considering pre-warming and intraoperative warming, even for those shorter cases. So intraoperative prevention. So let's talk about how do you intervene and talk about how they lose heat. So how would you intervene to prevent heat loss with each of these areas? So with convection, we want to limit body surface exposure, because remember, part of convection is just that rapid air exchange cycle in the OR that's just causing a breeze. So we want to limit body exposure as much as possible. We want to avoid wet surgical drapes and having pools of wet draping under the patient. And as much as our surgeons may fuss and our anesthesia providers, we need to increase the ambient room temperature in the OR. Radiation. Again, this is oftentimes due to the size of the surgical incision. So there's not a whole lot that we can always do to control for radiation. Now, radiation will also occur when you've got cool fluids that you're losing temperature from. But ideally, we want to go with the least amount of body exposure, the smallest incision that we possibly can. Evaporation, warm anesthesia gases. Again, avoiding cool irrigation, not spilling irrigation, just using it all over, not having irrigation spills. And then conduction. This is where you put that warm body coming into the OR on the cold OR table. You're going to lose heat. So we want to, that OR table surface, or the procedure table, if you're in interventional radiology, cath lab, etc., that is going to be where you get the greatest bang for your buck as far as warming. Robotic surgery cases, That OR table surface is going to be your largest surface where you're going to be able to warm the patient. So by the time we get to the PACU, we're really in rescue mode. Pure and simple. Ideally, the patient shouldn't be coming to the PACU hypothermic. If they are hypothermic, then your best approach is going to be forced air, and you're going to need to keep them in the PACU until you can get that patient completely warmed and normothermic. So how often should we be measuring temperature? So preoperatively, we need to have a baseline temperature in the preoperative area. And ideally, what you are using for temperature measurement in the preoperative area, you should be using the same approach in the postoperative area. Now, we know that intraoperatively, we're going to use different approaches. But pre-op and post-op, you should be using the same approach. You need to make sure that the patient is normothermic before they go to the OR. If they are not normothermic, it really should be a holding point, and we should actively warm them, because if they start lower than 96, and we know they're gonna drop, and they're only going to get colder. Now, I understand that in trauma patients and some of the cases that are coming straight through the ED to the OR, that's not possible. But whenever possible, we need to be pre-warming preoperatively. If we're pre-warming, ideally get a temperature on admission to pre-op, and then right before they go back to the back. Intraoperatively, the ideal is that we just monitor temperature continuously. Depending on the clinical practice guideline that you read, you will see recommendations to monitor temp in the OR anywhere running from continuous to every 15 minutes to every 30 minutes. I would say the ideal is continuous. And if that is not an option, then every 15 minutes. But you may need to drop down if there are a lot of risk factors associated with the surgery. And also, depending on the trends that you're seeing as you're monitoring the temperature. If you're monitoring the temperature and it's staying pretty steady every 15 minutes, you might be safe with every 15 minutes. If you're monitoring the temperature and it's dropping even just a little bit every 15 minutes, you may want to go to monitoring more frequently. In the PACU, if the patient comes in normothermic, then the guidelines will recommend on admission and on discharge. If they come in hypothermic and we are if we are using forced air, if we are active warming in the PACU, then you need to be taking that temperature at least every 15 minutes. If they come in normothermic, but they're barely normothermic, like if they're 36.3, 36.4, I'd say anywhere between 36 Celsius and 37 Celsius. I personally would monitor the temperature more frequently, because we will often sometimes also see after drop in the PACU, where we'll see the temperature drop after they get into the PACU. And again, the one area I think we're really not touching on is temperature management once they go to the floor. So we need to remember to remind bedside nurses on the floor that they need to monitor the temperature more rapidly. And I think they oftentimes they think about seeing a temperature spike and infection. But I think what you're going to see first is a temperature drop because of after drop where you get some heat loss on the floor. So we need to remember to make our bedside nurses on the floor and in the critical care units aware of that. But basically, bottom line, and I'm quoting Dr. Dan Sessler, and he is the anesthesiologist that is the guru in unplanned perioperative hypothermia. Basically, and this is a picture of our in-laws' house across our pasture on a cold, wintry day, kind of like we're having today. Most importantly, keep the patient warm. There's no right or wrong way to do it or special combination. You've really got to move towards risk-tailored interventions. Go back and look at that list of risk factors that I provided. Look at all of the various ways that the patient can lose heat in the OR. And then, or in the procedural area. It's one thing we always say in the OR, but we're finding that patients that are having long cath lab procedures and interventional radiology procedures are just as prone to hypothermia as surgical patients. So look at all of the risk factors, look at all of the routes where the patient could lose heat. Think about your procedure, the position, the duration, and then detail and design your intraoperative warming approach tailored to the patient risk and the surgical environment, the procedure, the patient position, etc. And so, Ashley, I think I've got 12:49 on my clock, so I know
This is perfect. Perfect timing.
for 10 minutes for questions and answers. So.
Yes, yes. So please, if you have any questions, please feel free to add them in the chat, as well as you have the Q&A option at the top, and I'll monitor those. But in the meantime, before we get to that, just a reminder, once again, you can add your questions in the chat, but also this recording will be provided for you afterwards shortly. You'll have a link to access the recording. And also, just thank you all for joining, and thank you, Dr. Hooper, for giving us this great presentation. Unplanned hypothermia is something that impacts our patients, and it's something that's preventable, and something that we all can do better at focusing on. And if we don't have any questions from the audience, I actually have a question for you. I wanted to know, do you feel like this is something that is focused on by the perioperative team as a whole? Like, do you see surgeons that are concerned about, the temperature of the patients, or do you see anesthesia mostly focusing on it?
I would say that anesthesia probably has a more narrow focus on it, just because anesthesia is the one that is constantly monitoring the vital signs, right? They're the ones that, the monitors are right there. The surgeon is engaged in the surgical procedure. So I laughed, and if there are any surgeons on the call, please forgive me. But as a very, very much younger PACU nurse, one of our chief of surgery, actually, and he was just a a great surgeon, a great guy, but he would sit there and tell you that anesthesia is the pilot in the OR, and he is but a passenger. And so he depends on anesthesia to go. Hey, the blood pressure is low, or hey, they're really starting to get cold. Can you speed it up a little bit? Now, that being said, I think that there is a mindset that the entire surgical team needs to have, excuse me, regarding hypothermia. Like the ambient room temperature of the OR. That should be a team effort and basically a team standard. It should be, this is the temperature that our OR is going to be kept at. And everybody should buy into that.
Right.
Okay. If you've got a patient that is extremely unstable and at high risk for hypothermia and at high risk for consequences related to hypothermia, I also used to laugh and say, there are some, I was in an academic health setting. And so, there's a big difference in what happens in July when you get that flip of your new interns and your new residents on July 1 versus where you're at on June 1st.
Right.
Okay. If you've got a patient that's at really high risk and we need to keep them warm and we need to get that surgery done, that is not the time when everybody needs to get to take one stitch as we're closing the patient.
Right.
And that's on the surgery team, that's on the surgeon, that's also on the OR circulator, because the OR circulator is the voice of the patient.
Yes.
And I am passionate. Nurses are the voice of the patient. That goes back to Florence Nightingale, Virginia Henderson.
Right.
We are the voice for the patient when the patient cannot speak for themselves. That is the OR circulator.
Right.
So it's a team effort. But sometimes, like every team, all of us have our strengths and our weaknesses.
Right. Right.
So sometimes it's up to somebody kind of to step up and call the question.
Perfect. So we do have a couple questions in the chat. So the first one, Marilyn, I see your question is specifically about the Baxter bed. And because this presentation is not product focused, I'll just ask that you send that question to medinfo@baxter.com. That is on this slide here, just so they can answer that question for you. But then we have a question from Vicky. Is there any other alternative for effective warming of patients with inevitable exposure, open bowel, for example, other than underbody warming intraoperatively? So we talked about those cases with those large surface areas, even your cardiac cases where you're prepped from your chin to your ankles, So what other active warming suggestions do you have?
I think that is where, and again, this is the OR circulator, okay, making sure all irrigants are warmed, making sure all IV fluids are warmed. Nudging anesthesia, it's pretty standard that they're going to warm their gases, but just kind of checking in to make sure that's what they're doing. Ambient room temperature, again, this is where, and this may be where, you just have to draw the line and go, well, this is what we're doing. But it's looking at all of those areas again where you're losing heat and taking advantage of whatever prevention techniques you can manage within the context of that large surgical exposure.
Perfect. Perfect. And we have one that I think we have time for one more. We have a question that came through the Q&A portion. It says, you mentioned the importance of consistent temperature monitoring throughout the flow of the patient. Any suggestions for how to best support those discussions? And what are your recommendations for the best route? And that was part of my question too. If you have facilities that use those inaccurate methods, such as the stickies on the forehead, how do you have those conversations to move away from what they're commonly doing into what is the best practice?
Well, it's operations and cost, right? And I will tell you, where we finally got traction in one of my former jobs was not related to the OR, it was related to sepsis alerts. And we were using tympanics. We were getting a lot of false sepsis alerts because of hypothermia. And the ClinSpec that managed sepsis started calculating how much a false sepsis alert cost with people, with lab, etc. And then we did an evidence summary, and there are ENA's got evidence on temperature measurement. There are plenty of sources, systematic reviews on temperature measurement. We presented to the nursing leadership what a false sepsis alert was costing, that we felt the false sepsis alerts were due to hypothermia due to inaccurate temperature measurement, and then presented the evidence, an evidence table of this is the most accurate route. And we switched not only one hospital, we switched an entire system. This was prior to when I was at Ascension. We switched an entire system from a mix of tympanics and temporal artery to oral. And we're able to reduce the number of false sepsis alerts. So, you know, if nothing else, shoot for this is the evidence and change the OR.
Yes.
But I will tell you, find your buddy who does sepsis work and see how many false sepsis alerts you're getting. And that may flip the switch in the entire hospital. Just
right. Right. They can't often speak against the evidence, right? They can't speak against that.
Combine the evidence with the cost.
Right.
Because it's operations. So you want to show, hey, you're wasting money here. The money that you're wasting will buy these new thermometers. And then you won't lose money in the future because of the false alerts.
Right, right. Well, thank you so much. I'm sorry, I saw we had a few last minute questions pop up, but I think we are out of time. Thank you so much, Valerie. We really appreciate you coming and bringing this information to us all. Such a great presentation. And for you that joined, thank you so much for joining us. If you would like, please feel free to send us an evaluation. Let us know what you thought, as well as let us know if you have any future topics you would like to talk about. So thank you all so much. And yes, this recording will be provided for all of you.
Thank you, everybody. Enjoy it. Have a happy holiday.
Yes. All right. Bye-bye.
Bye.